morning, everyone. Hope everyone can hear me okay. Happy Monday. I hope you had a great weekend. Welcome to our grand rounds. I'd like to give a special thanks to our sponsors, Boehringer Ingelheim and Janssen Pulmonary Hypertension. Thank you so much for supporting these talks. We also like to thank A Biomed for providing an unrestricted educational grant. This morning, we have a collection of our fellows presenting. Part of our educational mission at MHI is to train future physicians, and we've been able to expand our fellowships over the years, so we're very excited about the number of fellows that we have. Our first speaker is going to be Dr. Gamam. He's our cardiovascular prevention fellow at the Nolan Family Center for Cardiovascular Health, and it's been great to have him here. He grew up in the Twin Cities. He did his undergrad and his med school at the University of Minnesota, and then he went on to residency at Hennepin County Hospital. And he's been with us in the past year working on cardiovascular prevention in clinic, but also on several research projects. And so this morning, he's going to talk to us about the use or the appropriate use of these novel diabetes medications we have that can reduce cardiovascular risk using some data from Allina Health. So join me in welcoming Dr. Gamam.
Thank you for the introduction. So I'm going to be talking about SGLT2 inhibitors and GLP-1 receptor agonists and reducing cardiovascular disease risk in individuals with type 2 diabetes. And so why focus on this population? One, diabetes is a major cause of cardiovascular disease mortality. It's about 11% of the U.S. population has diabetes compared to like 6.9% 10 years prior. About 45% of those with diabetes have established cardiovascular disease. And just on the left is a chart showing the compared relative risk of individuals with diabetes and cardiovascular disease compared to cardiovascular disease only and diabetes only, and so the risk is quite high. And then intensive glucose therapy alone does not, isn't sufficient to decrease CV mortality with like conventional medications. And so here's a short timeline of these medications. On the top is the SGLT2 inhibitors, and in the boxed medications just show ones that had positive cardiovascular outcome trials. And so there's about like 4 GLP-1 receptor agonists and 2 SGLT2 inhibitor medications. So just to go over the data on SGLT2 and GLP-1 receptor agonists, here's a meta-analysis looking at SGLT2 inhibitors at reducing CV death stratified by individuals with ASCVD and those without ASCVD. And so we can see that there's about 17% reduction in those with ASCVD, and those without a history of ASCVD, there wasn't too much reduction there. And then here we're looking at MACE and similar findings, about an 11% reduction in those with ASCVD compared to no difference between the treatment placebo for those without ASCVD. And this is all in individual with type 2 diabetes. And then SGLT2 inhibitors are also reducing heart failure hospitalizations, and that didn't separate by individuals with and without ASCVD, an overall reduction of about 32%. And looking at GLP-1 receptor agonists, there was a reduction in MACE. That was also most prominent in those with ASCVD compared to those without. So the benefit overall in SGLT2 and GLP-1 receptor agonists is in secondary prevention for those with type 2 diabetes. And there's some other benefits for SGLT2 inhibitors, the reduction in heart failure hospitalization, and then also it slows the progression of CKD more so than GLP-1 receptor agonists. And then one of the advantages of GLP-1 receptor agonists is also you get the substantial weight loss with that as well. And so with all that, with all these new medications, the several committee guidelines have been adjusted. So now they're recommending those with established ASCVD or high risk for ASCVD start GLP-1 receptor agonists or SGLT2 inhibitors independent of the hemoglobin A1C. So my project was on looking at the uptake of these medications in the Allina Health system. And so despite the cardiovascular benefit of these medications, nationwide cohort studies estimate that about less than 15% of those with type 2 diabetes and CVD are on an SGLT2 or GLP-1 receptor agonist. And so we wanted to see what the uptake was in the Allina health system and then identify any potential barriers to access to those medications. So we looked at the Allina Health's electronic data warehouse. We identified patients in between October 2021 to 2022, and the medical and procedure history was obtained through ICD-10 codes. So here's a table looking at the population stratified by those with and without cardiovascular disease. Focusing on those with cardiovascular disease. About 63,000 patients with type 2 diabetes in the Allina health system. About 35% of those also had clinical ASCVD. The hemoglobin A1C between these two groups was similar, slightly more males in those with cardiovascular disease, and then some high rates of congestive heart failure as well. And so here's comparing the use of medications between these two groups. And so see, metformin and insulin are the and sulfonylurea's top 3 medications there. And then GLP-1 receptor agonist, about 14% in those with cardiovascular disease. So it was actually less than those without cardiovascular disease. And then the SGLT2 inhibitors was about similar between the two groups. And here we're just stratifying it by race, and so not too significant differences. Overall, I guess the use of these medications is low across all the groups, and so not much there. And then stratifying by gender, SGLT2 inhibitors are less frequently used in women compared to men. But overall, again, the use of these medications generally is just quite low. Here again, by insurance status, so we can see the SGLT2 inhibitors and GLP-1 receptor agonists are less commonly used in those with public insurance compared to private insurance. I guess overall, kind of the use of SGLT2 inhibitors and GLP-1 receptor agonists in those with type 2 diabetes with ASCVD in our cohort was less than 15%, so that's similar to nationwide estimates. And then the use of these medications was similar in those with and without ASCVD, and so despite going back to that chart, looking at the medications, the GLP-1 receptor agonists were even less commonly used in those with CVD. So although there was some differences between gender, race, insurance type, I guess overall the use of the medications was still low, and so that's that. And then just a table or some pictures from kind of showing how popular these medications have become in the public, I guess. And so there's a lot of discussion online, and a lot of articles written about like these medications. So I don't think there's a lot of discussion. A lot of people have awareness about them. And one of the things that we're working on now for like kind of next steps is like looking at how do we increase the use of these medications in our patient population. And so we're planning on doing this where physician could order a GLP-1 receptor agonist, and then a pharmacist can start the prior authorization process, titrate the medication, and then they'd follow up in 3 months with an APP. And so one of the major barriers is just kind of the follow-up for using these medications. And so that's one of the things we're considering doing next. That's about it. So thank you. Do you guys have any questions?
Do you have any temporal information on trends?
Or no, we don't have any temporal information for the trend. That'd be interesting to look at, see how that's compared to years prior.
Do you have any data about whether this type 2 diabetic patient, if seen by endocrinologists versus seen just by the PCP, was more likely or less likely to receive this new drug?
So we weren't able to kind of look at the what group saw them. So versus endocrinologist versus cardiologist, or primary care. But in general, the data shows that majority of these medications, looking at prescription, nationwide prescription data, that these medications are typically prescribed by primary care and endocrinologists and vary maybe like less than 10% or so by cardiologists. All right, thank you.
I have the pleasure of introducing our next speaker. We have Dr. Amr Idris, and introducing him is a little bit of a landmark moment for the section of imaging, as he's going to be finishing as our first ever MHI Advanced Imaging Fellow come June. We were fortunate that Dr. Idris joined us from Dallas. He chose to make the move with a strong clinical and research pedigree. In Dallas, he was chief fellow at Baylor Scott and White and had with him already 30 plus publications, as well as a previous ACC Young Investigator Award for work done in cardiac stem cells. Amr has been just a fantastic fellow, maturing quickly into an astute clinical cardiac and CT and MRI specialist. He has also been, even though we didn't intend for this to be part of the program, he's turned out to be just a gifted teacher for the general fellows, and he's been really instrumental in helping us figure out what we can improve for the fellows to have their future experience. So he will be giving you a fast-moving look at cardiac CT advances and future. When he's all done here, he will be taking on the role of a household cardiac imaging specialist at King's Daughters Hospital in Kentucky, part of the University of Kentucky Health System, and we will miss him dearly. Amr, the floor is yours.
Thank you, Dr. Cheng, for the great introduction, and good morning. So today I'll be talking about the current utilization and the future of cardiac CT. I'll try to summarize my last year in the next 15 minutes or so. But to be able to do that, I would like to go a little bit back in the history to 1971, when a British engineer, Sir Godfrey Hansfield, introduced the first CT scan, coming from an idea of looking inside a box without opening it. The first CT scan was for the head and brain. So Sir Hansfield used to work for a company called Electrical and Musical Industry that has a research branch, but at the same time, they were record labor. So they had over 40 albums. The most prominent one was the Beatles, and this actually looked it up in my Spotify, and they had really good reviews. They have about 30 million views over each month. So part of even a small contribution, we can say that musical industry helped developing the first scanner that was developed by EMI. Of course, we cannot neglect the bigger proportion here for the British Health Department in funding the first scanner and the work of Hansfield. So eventually, he won the Nobel Prize along with Cormack for their work for developing the CT scan. So the history of CT scanner go a long way since 1990, but it did not really take off until mid-2000s when they first introduced the 64 CT slice machines and equipments. So eventually, after that, a lot of studies came out for evaluating the cardiac CT and evaluating patients with acute chest pain, starting in 2011 and ending in 2015. How about stable chest pains? Also, studies started afterward in 2015 and eventually the ischemia trial in 2022. So what does that mean? Before 2012, we did not even in the guidelines, there was no mentioning of cardiac CT at all. So after all these trials came out in 2012, cardiac CT popped up in the guidelines, and it was a class 2B recommendations compared to class 1 recommendations for the other modalities for stress testing. These guidelines come each 10 years. So in 2021, the chest pain guidelines, after all the studies, now got popularity and was upgraded to class 1 recommendation for patients who have intermediate to high risk probability of coronary artery disease in both acute and stable chest pain. So after that, the utilization, you can tell here from the figure in the left, in the United States, the SPECT stress testing went down and the CT scan utilization got up. And that's really evident by our scan volumes here at MHI that got established by Dr. John Lesser and continued leadership by Dr. Cheng and Dr. Joao Cavalcanti. And you can tell here from the left side, the CMR in 2022 was about 2,000 and the CT scan volume is about 6,000 here in the past year. So where do cardiac imagers stand here? This is all true for all modalities. So we are involved in all aspects in cardiology and even in internal medicine and prevention. So our roles start here, and we are involved in all aspects: EP, heart failure, interventional, and cardiac surgery. So I will start with the most common indication, which is evaluating coronary anatomy and stenosis. Most of these pictures are from our lab. So this is a normal anatomy, and we can tell here there's an anomalous left stirrup coming from the RCA. I'll try to point it out. You don't see my, okay, that's fine. So there is an anomalous left stirrup coming from an RCA. This is an anomalous left anterior descending artery from the right coronary cusp. On the right side, you can see that this is a beautiful 3D rendering image here, giving us the anatomy. But why do I included this invasive FR? This utility has been utilized in the cath lab to determine hemodynamically significant lesions or not. But nowadays, we have it in non-invasively by utilizing the CT scan. So I'm not going to go into much details into this, but we obtained the raw data. We send it to an external vendor where they do their analysis and give us this beautiful color-coded picture here on the E, and give us like if it's hemodynamically significant or not based on the FFR in hemodynamics here. So what is the correlation between FFR-CT and invasive FR? On the left side, we see there is a great correlation, and on the right side, we see that CT-FFR improved the diagnostic accuracy of CT alone in the intermediate lesions. So trials came out validating CT-FFR, and these are COMP trials, and eventually it came out as a class 2A recommendation for intermediate lesions to help decision maker regarding the use of coronary revascularization. So this is a normal CT-FFR case. There is a proximal LAD lesion that we thought is intermediate and came out to be not hemodynamically significant with an FFR of 8.6. This is a male patient with chest pain. He has a proximal and distal left main and proximal LAD lesion, and it was hemodynamically significant. You see by the red color here, it was at 6.6. So patient was referred for coronary angiogram for further evaluation here. This is an anomalous. This is a great case. This anomalous RCA. This patient was in the middle-aged patient. He used to have exertional chest pain and was referred for CT scan. We did not see any plaque there, significant plaque, but we saw that there is an anomalous right coronary artery. But because of his symptoms, we sent him to CT-FFR to see how significant is that, and actually turned out to be significant. So putting all this together, the history, the CT-FFR, he was referred for surgical evaluation. Also, there is a great utilization by our interventional colleagues here for CTO planning, especially in difficult cases. So we can accurately provide them some angles, some CTO planning, the length, the cab, how much calcification, and this is hopefully will be able to cut down their timing for these procedures. Extending beyond the coronary arteries, of course, echocardiogram is still #1 modality for evaluating valvular heart disease, but CT scan is #1 modality for pre-planning for interventional procedures. So we can provide you accurately with the annulus size, the calcification, the access, but nowadays we also utilize it for other tools such as the ECV here, the extracellular volume fraction, by utilizing the Hansfield unit. And there is a great research coming out from our lab about this utilization as a biomarker beyond like the traditional biomarkers that we have. And also we can raise a high suspicion for patients who have a very elevated value for screening for amyloidosis. For patients who have difficult windows, we can also provide the great anatomical features here. This is a bicuspid aortic valve. This patient on the left side, we saw after 1 month, we obtained a CT scan, and you see there is a great thickening here in the leaflets in the right and the non-coronary leaflets. After 4 months of warfarin, this thickening has been resolved. Nowadays, we moved from TAVR, now we are doing valve-in-valve procedures. And this will help us determining for patients who are at high risk of developing complications. And this patient was a high risk for complications because we are looking at the valve to left coronary artery. If you see the red arrow here was really narrow, and there is high risk of coronary artery obstruction. So this patient, despite having 2 previous surgeries, she underwent a 3rd sternotomy because of the high risk of complication from intracatheter procedure. Now we also move toward the tricuspid valve and the mitral valve. We can look at the anatomy here on the left side. You can see there is a lead, and there's impinging, and there is incomplete coaptation of the leaflets here. And we can provide sizing for all the trial devices that we currently utilize in our hospital here. Same thing for the mitral valve. And this is a case of the tricuspid valve that has been replaced by Intrepid. And this is patient had an elevated gradient and underwent CT scan. And you can see there is a great thickening of these leaflets. So we provided explanation why this patient had elevated gradient and started developing symptoms. Also, infectious endocarditis. Echocardiogram still #1 because of the high temperature resolution and because these are really highly moving objects here. So we can still provide the anatomy, better anatomy. We're looking at the complications from infectious endocarditis, especially with mechanical valves when we cannot see clearly on the echocardiogram. So you can tell here from the arrow here, we see like early thickening of the wall. So this is an early abscess. We send it to a PET scan. It light up, and patient was referred for surgery for repairing. Also, we can provide accurate LV and RV function. I can provide you with any view that you would like from the TTE, especially in patients who have difficulty obtaining windows and pictures from the echocardiogram. This is a great case. Why I chose this case for HCM patients, not just for simply diagnosing it, but also for pre-surgical planning. This patient had the significant symptoms that was referred for surgery, but it's just not like simply by the septal thickening, but also there are a lot of other features that can actually contribute to the obstruction, such as the bifid papillary muscle, anomalous insertion. So we provided great details for the surgeon to be able to repair this patient. So this is actually the cine images, and this is the 3D images here. We see like the bifid and the anomalous insertion, in addition, of course, to the septal thickening here. Also, we utilize it for prior to AFib ablation, providing the anatomy for the pulmonary veins. Prior to Watchman, looking at the left atrial appendage morphology, looking at if there's a thrombus or not, and what is the rule for CT scan versus TE for evaluating a thrombus? This is a meta-analysis. It showed there's 100% sensitivity, 99% specificity for CT scan. TE is still #1, but it's a great alternative tool for patients who cannot undergo TE, and especially in the era of COVID, that was a great utilization in our lab for that. We can also provide pre-Watchman planning. This is stimulated sizing angles. So this is a patient who had a Watchman. On the right side, we see the echocardiogram. I can provide you the exact one on the CT scan as well. We will provide you the angles, and hopefully this will cut down the time for the procedure. Post-Watchman, we can see here incomplete endothelialization. This will help us determine when do we stop the anticoagulation for this patient. Of course, heart failure, LVAD patients, we don't evaluate it like this. It's just a beautiful picture for LVAD, but it's occasionally utilized by our service for providing some explanation for high alarming for these patients. Of course, cardio-oncology as well. This is an invasive cardiac tumor, turned out to be leiomyosarcoma. Peripheral arterial disease, EVAR evaluation, and on the right side, you can see there is subclavian artery stenosis for a patient who have undifferentiated high blood pressure on the right side. New technologies, of course, there is a lot of exciting things coming from to our imaging world. There's a new machine called Neonatum Alpha Photon that improves the spatial resolution and hopefully will decrease the radiation as well. The novel applications, all of these, just disclaimer, all of these under research. We don't utilize them yet clinically. With the majority, we don't utilize them yet here. So beyond the traditional, plaque features for high-risk plaque features, there is now something called delta FFRCT, wall shear stress, and in addition to axial plaque stress. And these are under studies to provide some further risk stratification. The blood status analysis in on the A and B for patients who have a TMVR device, looking at the flow dynamics and see what happens to this patient after we replace the valve. And on the C, we can see the flow dynamics for patients who have left atrial appendage thrombus or high risk for that, so we can provide them a risk beyond the SHATS-FAST score that we currently utilize. The last one, the E picture here, the shear stress post-TAVR in the aortic root may be helpful in determining why some patients develop degeneration or halt. So this all under investigation. Also RadioMix. This take off in the cardiac oncology ward, in the lungs, in the breast cancers, but it started a little bit some investigation here for evaluating plaque beyond the human eyes. So also there are some studies about the strain utilizing CT scan as well. Lastly, we utilize AI. Now it's coming into everybody knows ChatGPT. We have it now. They started coming into the CT for AI plaque quantification and looking for some plaque that are not detected by our humans, or reclassify our patients. This is pictures from a Clearly lab, and this is our research on plaque analysis. I'm not going to go much into details in that, but please join us in Boston to I'll be talking about this research there. So the sky is the limit in CT scan and cardiac imaging, and actually here the space is the limit. So this astronaut had a defect in his suit, and they were trying to detect what is the defect under the CT scan here. I would like to take this opportunity to thank all my attendings here from MHI Imaging, Doctors Lesser, Cheng, Cavalcanti, Newell, Miedema, Nickelbein, Lin, and Shelbert, and Orbach. Of course, David and Jenna, and all the technologists, all the researchers who contributed to my training here. And this is my lot of great memories. Again, few parents here, and time to go back to exercise. And I'm really excited that I will be joining University of Kentucky Healthcare Kinsler Hospital, where my journey started 10 years ago as a research fellow. Thank you.
Oh, beautifully done. If I may say something, is that you have a great career ahead, and the knowledge that you got here, this backbone that just started, it's so solid that I'm sure that you're going to be able to train a lot of other people and benefit many, many patients. Definitely, please stay in touch. The world became small, and we're so fortunate to have had the chance to train you. So.
Thank you. That means a lot to me. I'm really confident that with my training here.
Good morning again. It's my great pleasure to present our Clinical Advanced Heart Failure Fellow, Dr. Ruben Crespo. Ruben received his MD PhD degree from a combined program, University of Puerto Rico and Mayo Clinic in Rochester. And his PhD focused on molecular biology of cardiac regeneration. He then completed his internal medicine residency and cardiology fellowship at the University of Minnesota. He has over 20 publications and also received AHA Young Investigator Award in 2022. He also had a great passion for mechanical circulatory support, and despite his very busy clinical fellowship here, he actually was managed to present 3 abstracts at the ISHLT just this past month, and today he will share with us one of his projects. So we've been very, very lucky to have him here. He's been inspiring, he's an amazing clinician and a great researcher, and he's wonderful at stats. So we didn't have to bother Ross too much. So welcome, and looking forward to hearing your presentation.
Thank you, Dr. Ruben. So I'll be presenting some data that we have from our institution about RVAD placement in patients with heart failure that underwent LVAD implantation, and show what the data shows in these patients. So As far as RV failure, it can occur about 20 to 40% of patients after an LVAD has been implanted. And in turn of these patients, about 5 to 10% of those were required on RVAD, 15 to 20% longitudinally after an LVAD has been placed, and this is like weeks afterwards, will be requiring some sort of inotropic therapy to support the RV after the LVAD has been placed. And the mechanism of RV failure after an LVAD has been placed, it's pretty broad. So you have an increase in the preload in the RV, which was not accustomed to, but now that you have improved flows on the left side, that RV is seeing more preload than it has historically has been. There's a decrease in contractility because as you are decompressing the LV, there are septal shifts and different myocyte alignments within the septum that can also alter the way the RV contracts. And then if there's any pulmonary artery remodeling, which is usually the case in these patients because they have type 2 PH and there's intimal thickening of the pulmonary arteries. The RV, in the setting of all of these changes, still has to contract against this remodeled pH. Even if the wedge goes low, there's still some degree of resistance or increased PVR in these patients. And there's been a lot of risk scores and numbers that you use to predict which patients after an LVAD will develop RV failure. But these are just risk scores. They don't mitigate the fact that the patients will have RV failure. They'll just tell you that there's an increase for it, but not what to do with it. And when we define RV failure in these patients, we used definitions from the INTERMACS registries. And the most recent ones that I'll just point out down here, they're pretty broad. So if we see patients with peripheral edemas or ascites or JVPs that are engorged or greater than 16 of a CVP, LFTs that are high, et cetera, they already kind of get categorized as of RV failure. Obviously, if they need any sort of temporal or durable RVAD, then of course they by definition meet what RV failure is, or inotrope therapy, the length of the inotrope therapy. So it's a pretty broad definition of what RV failure is. And aside from those hemodynamic parameters, there's other parameters that you can look at, echocardiography parameters, and there's a number of measurements that you can take in order to determine if the patients have RV failure after the LVAD is placed, or even before the LVAD is placed, if they're at high risk of developing so. Other non-RV center parameters that are mostly around the LV or the use of ECMO or other MCS, inflammatory lapses, et cetera. And when we look at the outcomes in patients with right heart failure after an LVAD is placed, what we see is that obviously patients that have RV failure have a greater prevalence of needing some sort of temporary support, either with machines or with inotropes, and that's not surprising. And then the natural evolution is that a lot of these patients, after a couple of months, will either still be on inotropes or some sort of MCS, or they'll have high mortality, or some of them do revert back to a state where the RV can then function without any sort of help. But again, within the year or so, the complications of the patients that have some degree of RV failure are greater than those that do not exhibit any RV failure following the LVAD implantation. And this also translates to mortality within 24 months. This is data from ISHLT registry just showing how the different degrees of RV support, whether it be inotropes for under a week, greater than 2 weeks or 3 weeks, or RVAD. If we look at the patients that actually are to the point of needing RVAD, the survival curves are a bit abysmal and very worrisome for these patients. Same when you cluster time of death, HF admissions or GI bleeds, it's even worse. So even though at this time point there's no randomized study saying anything in regards to putting patients on RVADs if they have RV failure. Societies, and in this one specifically, the European Society of Cardiovascular Surgery actually have some recommendations that for patients that you have predicted with your hemodynamic risk calculators or clinically that they're at a higher risk of having RV failure, then you should consider implantation of an RVAD in order to decrease mortality or morbidity. And these retrospective studies that these guidelines quote indeed do show that placing patients on RVADs prophylactically, as this one is P versus delayed, which means patient has the RVAD, they've been in the ICU for who knows how many days and who knows how many presses, and you realize, yeah, we should put some sort of an MCS for the RV. Compared to the planned, the mortality is actually, or the survival here is actually pretty low when you do a delayed MCS approach for RVADs following LVADs. And again, this is just showing kind of a similar trend when you compare delayed versus prophylactic use of RVADs. In this study specifically, this will be the better slide for it. They actually took patients regardless of LVAD that were either in a post-LVAD state or post-cardiotomy shock, so these did not receive any sort of LVAD, or post-transplant. And then they divided the patients into which ones that had these sorts of surgeries had an early or a late LVAD or RVAD implantation. And what they saw is that immediate RVAD use in post-cardiotomy shock or LVAD placement or post-transplant patients with RV failure actually confers a better survival for these patients. Yeah, and then as far as the one of the things that are also quoted in the guidelines, as we're talking about RV failure and these things, like, oh, what about the use of nitric oxide? That's something that it's used all the time, or ibuprofen, these things to help the RV hemodynamics after surgery. And as far as like nitric oxide, I mean, even though it's used and overused after surgery, there's no actual clinical data showing that it does anything for the RV and let alone survival. Physiologically makes sense. We will continue to do so, but this is just to highlight how much of sometimes the things that we do doesn't necessarily have any backing of clinical data, unfortunately. So here at MHI, we had about 75 patients over the last couple of years that actually had RVAD insertions after the LVAD was placed. And interestingly, some of these RVADs were dichotomized into planned RVAD procedure, meaning that the patient in the OR right after the LVAD was placed had an RVAD placed as well, versus those in which the RVAD was done as a bailout strategy. This means these patients came out of the surgery, went to the unit, something happened in the unit, and then they either go back to the OR or they go back to the cath lab and they get an RVAD. So we had two groups, which were again a delayed or a bailout, and then an early or a planned procedure cohort. And what we saw is that basically there was no statistical significance in some of the baseline characteristics between these two populations, except that the patients that were, the patients that received the RVAD as a bailout, as a planned procedure were Intermax 1 or 2. Those means that these are the patients that the way the Intermax classification labels them are like the crashing and burning patients. So the interesting thing is that the sickest patients that went into the OR were the ones that actually got a planned RVAD versus the ones that were a bit more stable and had less MCS, either with ECMO or Impellas or Bipellas or whatever. They were actually the ones that had less of those were fell into the bailout cohort. So presumably they were not as sick. However, when you look at the hemodynamics and some of these scores that we use, like the PAPI score, which basically is a good measurement of RV, it accounts for like RV pulsatility over pulse pressure over the CVP. They were both terrible in both groups. Echocardiography, though, showed that the patients that had the planned RVADs were either labeled, 2/3 of them were either labeled subjectively as moderately reduced or severely reduced, different from the planned group where visually the RV was either normal or just mildly reduced, although the TAPSI, and it's not here, but the S prime and some of these other parameters were actually not statistically significant, so it was a very subjective view. The length of the ICU stays between both populations was pretty much the same. And as far as the percentage of patients, most of them were centrally cannulated with a Centromag, and about 30% of those had Protect Duo as far as the type of RVAD that they got. But the data doesn't lie. What we did see is that even though the patients that went into the OR sicker because of higher or lower Intermax with more MCS, with echocardiography findings of RV failure, and low PAPI score, but were cannulated as a planned procedure, so at least they never left the OR without some sort of biventricular device. The survival was actually better in these patients where things were planned. And this translates even at the 1 month, we could see the breakup, but that translated into 3 months, 6 months, and as well as at the 12-month state. So the things that we can conclude from this study is that the baseline characteristics are not that significantly different between both groups. The patients that had planned RVAD were arguably sicker, lower Intermax score, more prevalence of some sort of MCS going into the surgery, yet they did better than the ones that were not, than the bailout group that presumably are not as sick. But I will argue that the invasive hemodynamic comparison showing that they're not statistically significant argues that both populations are actually almost equally sick. They both have really low bad PAPI score. They both have some sort of whiff of RV dysfunction, be it by echo and by hemodynamics. And I think that the overarching theme here, and it has changed our practice now, is there any whiff clinically, hemodynamically, or imaging-wise of all of them together of some sort of RV dysfunction, and a patient's gonna go on an LVAD implantation, then now it's part of the conversation when we have our meetings, whether or not an RVAD should be placed prophylactically, knowing that internally our data shows that these patients will definitely do better. And to this end, based on this data and other that we have presented and others as well, there's a randomized trial now at Mass General that is actually looking at randomizing patients that are going to have LVAD placement to either have early RVAD placement with a Protect Duo on our Impella RP versus none, to kind of then show in a randomized way that these patients indeed will benefit from RV mechanical support. And I'll thank you, Dr. Renowitz, and everybody in the heart failure team, obviously, for being so awesome with me this year, and it's been a pleasure working with everybody. And I'm happy that I'll be staying local and working with all of you. I think I'll be at Mayo, but nonetheless, we'll be sharing patients, I'm sure. So, so yeah. So, any questions, I'll be happy to answer.
I have a question. Thank you for the presentation. Do you have a sense of the denominator of just LVAD patients that go in and then the percentage of them that end up getting into the bailout situation, right? Because the proposed change in treatment is for the now potentially looking at a much larger group of which a fraction end up getting the bailout. Do you have a sense of how frequent that happens?
How frequent it happens that we do the bailout? Or?
So you do an LVAD,
Yeah.
and you have a number of patients who get the LVAD and they're uncomplicated. They
Yeah.
don't end up in the bailout category. And then a percentage of them do. Do you have do you have some sense of what percentage it is that?
Yeah, I think it's very close to in the initial slides of what the spread is nationally, and I mean, and this varies within institution by institution. Usually, it's like between 20 to 40% of patients. I would say that here maybe it's in the middle. I would say maybe a third of patients or less will come out requiring some sort of biventricular support from the OR. I think the thing that has changed is the Intermax. You know, so there's this new allocation system now where patients with LVADs used to be higher on the list, or they could be placed at a higher status for heart transplants, and that has changed to benefit more the people on ECMO and the sickest patients. So that made a lot of programs kind of recalibrate a little bit in how they use their LVADs, and now you are thinking more, should I transplant this patient that they're kind of hemodynamically stable-ish, but they're still sick, versus if I put an LVAD, they might not get a transplant for many years. So then the LVADs now are, in some places, are being placed more on the cardiogenic shock patients, Intermac 1, they're crashing and burning, you're thinking like, what am I gonna do with this patient? So they put an LVAD, and I think that's where, in those situations, the RVAD numbers actually go up, and I would say like more than 50% of those patients will need an RVAD because they're going into the OR really, really, really sick, as opposed to the other historical data where it's like 20 to 40% because those were the stable-ish patients. So it depends also on how is your program utilizing LVADs.
Maybe worth considering looking to see if there's something that tips off the patients who didn't end up getting into the bailout situation, just LVAD only compared to this, especially when you're looking at RV hints. Maybe there's something that can tell us the two groups apart.
Yeah, I think the conclusion or the lesson from it is it was a retrospective data. So I think what Ruben actually stressed out was that the ones who are bailout, they probably retrospectively looking, they should have gotten the RVAD. Because when you looked at all the hemodynamic data, and I think the only thing that was a little different was the Intermax, but you know, all the objective measures of, you know, the TAPSE, the PAPI, the RV size. So I think that was a lesson for us, like Ruben said, that now this is part of the conversation when we're actually presenting patients for LVAD implantation. And we basically would look at this data, we're like, oh my God, how then we actually think about putting it up front? So, you know, so there's kind of a clinical benefit from that study.
Visually, the RV looked worse, right, in those that were.
Visually, it's the more, you know, when,
Yeah.
I mean, most of us echo board, you know, when they say mild RV dysfunction, what does that mean? You know,
Yeah.
sometimes just a visual interpretation, and that's one thing that was different, but when you go to the objective, like
Yeah.
what's your TAPSE, it's not a difference.
Yeah.
Or when you look at the PAPI, which is a hemodynamic component of what the RV function is, it's not that different. And my takeaway was basically what Dr. Renowitz said, even though you can say that there's a difference echo-wise with that interpretation, I think it's more like if you have any whiff of RV dysfunction, even if it's mild and you're having this sort of a patient profile, then thinking about RVAD might be a good idea.
So on that line, how long do they need RV support for? So is percutaneous better than, you know, committing to a full BiVAD? Is that, what do we know?
From this data, median time that they require the BIVADs are about 14 days. That's plus or minus 10 days. I think that by and the ones that after this data then pay more attention to the ones that we then end up having on BIVADs, I think by 20 days or so, we already have a sense of where are we with this RV and are we not going to recover or not. That's part of the analysis to looking at the PROTECT versus the Centromag as far as the length and the outcomes and all that, and see if there's a difference in this population between the centrally cannulated or the peripheral cannulated. That's in the works as well.
Yeah, the only thing is that, PROTECT is usually a bailout because, if we already discussed it and we planned that the RVAD will be placed, then the surgeon places the RVAD. We have a very nice protocol. It sounds kind of, aggressive, but it's actually, for the patient, it's very nice. Patients just have cannula sticking out of their, upper belly, and our surgeons decannulate at the bedside. So we actually don't need to, they put a graft and they just cut the graft and it clots off. So it really, doesn't clog the OR. The OR comes to the ICU. And just from my own, experience, I feel it is more comfortable for the patient rather than having a, big kind of a hose in the part of the neck. And again, I don't really remember how many planned protects we did. I mean, it's always, an emergency or urgency.
Yeah. I have a question. Maybe you answered it, but I missed it. So, how much does the clinical scenario play into this in terms of predicting who's gonna have RV failure? For example, I think you alluded to cardiogenic shock. So, acute MI versus post-op. Were you able to look at that kind of granularity?
So I would say that, and I've not presented here, but we're working on the paper for this. In both populations, if you use a lot of these risk scores, they all would these risk scores would have predicted for both either the bailout or the non-bailout. And probably is a way because we're obviously selecting patients that need it, even as a bailout. But if we were to pretend like we didn't know that was the case and we just use this data, I feel like the PAPI score, which has been pretty validated, is one of the things that really just inform you that these patients are going to struggle after the LVAD. As far as the etiology, the spread between ischemic and non-ischemic cardiomyopathy was pretty much even between the groups, so it's not like I can say, oh, my patient might actually benefit maybe more from this, or I should think more about this versus the non-ischemic ones. It didn't pan out that way. It was mostly just almost a hemodynamic component that we were able to say, okay, this patient's, especially now knowing what we know, you have a low PAPI. It's been shown before to predict bad outcomes with a low PAPI. In our case, we should then think about really supporting this RV coming out of the OR and then and reducing the risk of mortality. That will be the one thing that of all of these things that it's really panning out. Because we're also looking at how much pressors did they get in the OR, or how are they coming out of the OR? Is there a difference in this bailout people that maybe can inform the patients in the OR, like, oh, wait a minute, should we do an RVAD because this is how much we've been giving the patient, and surprisingly, it's actually the same. They're coming out of the OR almost with the same amount of everything, except that one has an RVAD, the other one doesn't. But yet, the bailout ones do worse. And I think it's what is the profile coming into the surgery. I think it's what's the most important versus what's happening in the OR or post-op. I think it's showing us that coming into the OR, they're already struggling, and there might be other things that we're missing, but because of the acuity of these patients, how things were placed rather quickly for the VATs and all that we might be missing. Maybe more advanced imaging, et cetera, for looking at how is this RV before the LVAD is placed, that we can get more information on.